So as this audience knows, most of the applications for MIS surgery has involved the lumbar spine. So I'm really excited for our next talk by Dom Coric from Charlotte on MIS applications in the cervical spine. Dom?
Thanks, Claude. Always a pleasure following Juan. It is never easy to do, but always a pleasure. Congrats on a great meeting, Eric. Congrats to Zach and Charlie as well. It's a phenomenal meeting. Juan was just up here, and his meeting in Tampa is going to be phenomenal next year as well. We're going to spend some time talking about the final frontier of MIS. So this is my disclosure. And when we talk about MIS, we typically talk about the thoracolumbar spine. The posterior cervical spine is something that is really not been touched except by Mike Wang, who talked about this in 2006. And as usual, Mike was a man ahead of his time. So you ask the question, well, if Mike has been talking about this since 2006, why isn't he up here giving this talk right now? And the reason is because he's talking after me. And Mike, you can't talk every single time. So the reality, though, is that he was literally a man ahead of his time because the technology wasn't there at the time and able to do this procedure. Our first two speakers in this session did a fantastic job of talking about how that technology needs to be at a certain place in order for MIS to become safe and reproducible and effective. And that technology simply didn't exist until the current nexus of instrumentation and navigation. And so, again, Mike, a man ahead of his time, but not quite ready to deal with some of the issues. The first two speakers also talked about classification and knowing something when you see it. I think if you look at some of the standard posterior cervical approaches, we've all seen these kind of notoriously bad aesthetic and pain outcomes. And it's not just aesthetic and chronic pain associated with these types of incisions that get pulled apart, but it's also wound infections. A lot of these are trauma patients and they're older patients and they're laying on these incisions. And so we can have some really bad outcomes directly referable just to our approach. And if you look at the MIS, again, I'm no expert at classification, but as a simple country neurosurgeon, I'd say that's MIS. That patient's going to do better. This is a 74-year-old patient who came in with a type 2 odontoid fracture. She had a displaced fracture. She had cystic change before her fracture. This is something that was not going to do well with any kind of external fixation. Halo is a death sentence in this kind of patient population. Anterior odontoid screw, not a good option at all with the swallowing difficulties, et cetera. So posterior cervical fixation can be fairly morbid with a midline incision. And instead, this is a lady who gets operated on, goes home the next day without a collar, and ultimately has that final wound healing at her 1-year follow-up. You can barely see her incisions. And so, like I said, cervical pedicle screw fixation, the concept has been around for a long time. Lubumi talked about this in the 90s. And so we know there's feasibility here, and we also know that there is a robust biomechanical situation. Again, I'm no Pat Warden, but having said that, I can look at the picture on the right and compare it to the picture on the left and say, this is larger diameter screws, longer screws that are essentially triangulated. This is biomechanically much more robust than the simple lateral mass fixation. And so you say, all right, great. Well, if it's so swell, why isn't everyone doing it? If it's biomechanically robust and it is feasible, why isn't everyone doing it? Because the way that it was done by Abumi and people earlier was the open incision, because the navigation didn't exist to do this reproducibly. So you'd have big midline incisions. To get the pedicles, you have to go laterally. You're pulling against your muscles. The wound looks even worse. And it is a technically very difficult thing to do. But our improvements in technology, like so many things, have opened the door to MIS now in the posterior cervical spine as well. And so this is our first kind of proof of concept experience. It was published 4 years ago, so we've been doing this for a little while now. This is a navigated percutaneous cervical pedicle screw approach. It is 100% muscle splitting. And again, here's some of the data from this initial proof of concept. We've done many more many more patients since this time. It's a lot easier to show than it is to talk about. So I'm going to go over a couple of cases quickly. This is 69-year-old, and you're not going to catch us sleeping in North Carolina. So we're going to do our very first minimally invasive posterior cervical case on a patient who is a complete quadriplegic. So we have very little to lose. But this is his dramatic fracture, C6-7 fracture dislocation. I think just about everyone would say this probably needs to be done 360. And so this is how it's done. Standard positioning, prone, Mayfield, Jackson table. Prep wide, you got to go super wide. You don't realize that pedicle trajectory is a lot more lateral than you thought. When we first considered doing this, we thought, are we going to have enough tissue in the middle there to do this minimally invasively? And the answer is there's a ton of room because you're so far lateral. You get your reference frame, you do your spin. This is a looking at the screen video game kind of operation. You can see Vince, one of my our junior partners on the left and me on the right, kind of looking up the screen as we're doing this. You see the paramedian Wiltsey type incisions with the separate fascial incisions and the reduction towers, standard drill, pilot hole, tap, screw placement, and then percutaneous rod placement. Here's some dermabond on the skin. Here is the final construct, and you can see biomechanically very robust. This is not something you need to put patient in a collar on. They could be mobilized right away. This is not immediate intra-op. Here is the instrumentation that was used, longer, bigger diameter screws. Here he is with a CT scan at a year. You can see he's fused posteriorly, he's fused anteriorly where he had his anterior fusion. Here's a 44-year-old, and so I said, great, this is for all our paralyzed patients. This patient comes in completely neurologically intact. And if you look at the MRI, you see anterior disc disruption, you see massive posterior disruption as well. So even though not a dramatic injury as we saw in the first time, still a pretty unstable fracture. So he undergoes anterior fixation. He still has a perched facet. He undergoes posterior fixation. And in this particular case, you don't always have to cannulate the pedicle all the way through. You can do what we call a pedicle inlet trajectory, which is that same lateral to medial trajectory, but you stop if the vert or the foramen is too close. It still gives you bigger diameter screws and positive triangulation. Again, here you see the reduction that was able to be done with the posterior approach. There was a MIS reduction plus the fusion and the final construct. Here, another case, this is in between. This is an Asia B, so an incomplete spinal cord injury. Obviously unstable ankylosed spine, multiple levels would have to be done posteriorly, and has an anterior posterior. And again, if we go to the posterior fixation, see how robust it is. We see the size of the screws. And again, if you look at the incision compared to a midline incision, that is a huge, big difference in someone who's going to be in the trauma unit and is going to go to rehab, et cetera. So here he is at 2-year follow-up, final CT. And then this is an interesting case. I'll run through it. This is an 88-year-old seen as a second opinion. He has this kind of ankylosed spine as well, this bony chance fracture, so unstable fracture. And he was actually consented for a C2 to T2, and they asked for a second opinion. And we talked about doing this MIS in this neuro-intact patient who was 88 years old. Here's his intra-op. You can see the reduction towers, the angulation of the screws. Again, the individual screws. And if that is an open incision C2 to T2 in a guy that size, he's going to have a hugely morbid incision. And that's his collar that was on for 24 hours. If you ever fish those out of a trauma unit after a week or two or at rehab, Those things are absolute disaster petri dishes. And again, the patient is not laying on his wound. It is a muscle-sparing kind of incision, hugely robust construct. You can see the screws long, immediately triangulated. So again, there are challenges like anything else. You know, this is a technique, it is the final frontier, so we're just entering now. We're working on getting good bone graft back there. We know that has to be done. Trauma, 360s, those are great cases to do this for, not every indication. Navigation accuracy, there's a trick to it. So bottom line, though, is that we're at a stage now where technology, that nexus point has been reached, and visionaries like Mike Wang can be met by the rest of us, and we can bring minimally invasive surgery to the posterior cervical spine. And I think this is a technique that is going to be expanded in the future, and it's here to stay. It's not flying cars. The future is now. Thank you for your attention.